party to something I've missed out on, so I'm very disappointed. What we're going to do today is just share with you the work that we've been doing in Dudley to develop our multi-specialty community provider, which is one of the new models of care, part of the Vanguard programme. So there's 3 of us. My colleague David's going to share with you the background to the new model of care that we've been developing in Dudley. My colleague Joe from the CCG is going to share with you the new model of care, what the model of care actually is. And then I'm going to just finish off by sort of reflecting on the public health perspective, really, what some of the opportunities are and some of the challenges are from a public health perspective. So I'm going to hand over to David, first of all.
Thank you very much indeed. Does this work? Oh, okay, right. So we have a number of fairly significant challenges to health and social care sustainability. For example, if this works, what am I pointing it at?
What's the pointing at? No, go. Yeah, go. Sorry.
Oh, funding pressures. Funding pressures, austerity and political choices, meaning less money in the system, less resources available, combined with staff pressures. A large number of NHS and social care staff are coming up to retirement, and of those who remain, many have an outdated skill mix that was designed for people working in the acute sector or in primary care, but not necessarily designed with the current challenges of long-term conditions that transcend hospital and social care and community boundaries. And then we have population pressures with the increasing prevalence of people with long-term conditions. An ageing population in itself doesn't necessarily mean greater health expenditure. However, if that ageing population has an increasing proportion of people with long-term conditions, those are the people who are predominantly using NHS and social care funding to look after them. And then the changing expectations of the public in terms of what is available and what could be available, things like the new anti-cancer drugs and so forth, changing expectations and increased demands for 7-day services, for example, treating people at their convenience. So all this means that there is a widening gap in social care and health care in terms of the needs and the resources and services that address them. Now, the solution to this is proposed by Simon Stevens as the 5-year forward view. It came out a couple of years ago and offered 5 potential solutions that are being piloted in different areas. One of them is this multi-specialty something or other, can't read it. Another one, integrated primary and acute systems, so that's sort of hospitals running primary care services effectively. Work in care homes, urgent care and acute collaborations of hospitals. And then underpinning all that, sustainability and transformation plans engaging providers on a wider regional footprint than the local health economy. Now, Donald Trump says that it's America first, but I'll let you into a secret. He's not always right. Sometimes it's Dudley that's first. Because if you type in multi-specialty community provider into Google, the first thing that comes up is Dudley, which suggests that there's something quite special about what's going on. What's so special? Well, the model has been under development for several years, about 10 years at least, of trying to sort of bring together primary care and closer working relationships and work particularly in the community. We've got a thriving community and a voluntary sector. And a focus on tapping into community assets. Both the Council and the CCG have a very public health orientated mindset and engage strongly with the local community. A major impact has been all GP practices in Dudley moving onto the EMIS web platform, which has benefits both of the GPs who are able to use templates when they're seeing patients that are designed with a common single template for processes and consultations and drug alerts and health checks and so forth. They can all use the same template and patients can get the same treatment. But equally, having all GPs on the same data system makes it very much easier to do data analysis on an incredibly rich source of clinical information. There's a long-term conditions framework which we've been helping the CCG to develop, which is an alternative to QOF. GPs in Dudley for the last couple of years have not been following QOF, but they've been following our own bespoke version of QOF with our own locally determined indicators, evidence-based, and we've got new models of care that are rooted in primary care and building on from that. So what does the MCP look like? Well, it's an integration of primary care, community services, mental health, outpatient secondary care, public health services and adult social care into this single multi-specialty community provider, or MCP, which is putting out a long-term contract, something like 15 years potentially, to sort of future-proof it and make it more robust to, for example, the whims of electoral cycles. It also means, with a 15-year contract, that you've got a period of time that you can actually make some meaningful observations in changes over that time in a population's health. It's focused very much on outcomes as opposed to paying for units of activity, and the outcomes in turn are very much related towards prevention, community interventions and supporting a new relationship with people in terms of helping people to support themselves and helping people to support one another. And part of the work around long-term conditions has been putting that into this overarching outcomes framework, which is the performance measurement tool for the MCP provider. I'm going to hand over now to Joe, who's going to talk a little bit more about that from a CCG perspective.
Okay, and so when we look at what are the principles behind the MCP, we start with the individual. So it's to maximise their potential for the individual to improve their health and well-being. We've then got the staff working within the MCP to maximise the potential of staff to improve their effectiveness, to doing what they do best for caring for those individuals. And then the whole society, so it's across the whole health economy, is to maximise the potential for staff and for patients to improve their effectiveness collectively in working with each other in a partnership sort of arrangement. Okay, so when we look at what we're trying to do, it's about getting the maximum we can out of the resources we've got, and it's about shared ownership, responsibility and shared benefits, both for the people working, the staff within the MCP, but also for patients. And this big thing here around teams without walls, so this is not, it's about breaking down the usual barriers of hospital, community, primary care, and actually having a team of people working collectively for the population. So taking those barriers away, taking the walls down, and actually working in a shared common theme way of working. Okay, so this is our new model of care. So the new model of care that we're designing is with the teams without walls. It's about having the person in the middle. They're the most important person there in the middle of it all. It's then based around the GP practice, so it's based around the registered population with the GP practice. And then what it is about bringing services together in a multidisciplinary approach for patients. So basically, there's three aspects to the model of care. There's access. So we actually, some years ago now, we went out to our population and we asked them, what's important to you? And that's what formed the themes that go through the new model of care. So access. For us, for the working population, who doesn't obviously access their GP that often, but when they do want to access the GP, they want to access it in a timely manner, as a time that's convenient to them. And so that was really important, the key theme of access. Next, you've got our long-term condition population. They predominantly wanted continuity of care. So when they had to have their regular health checks around diabetes, COPD, asthma, they wanted to see somebody who knew them, who knew their case. They didn't want to keep seeing several different people at different times. They wanted that continuity of care for them. Then we have, which is predominantly what the model is here, is around coordination. So this is around, potentially for our highest risk people, highest risk of admission to hospital, our frail elderly. They wanted They wanted coordinated care, so they wanted services to come together. They didn't want to see a district nurse one day, a case manager another day, their GP practice another day. They wanted the services coordinated, talking to each other. So what we've actually created is this multidisciplinary approach. So we've actually got a multidisciplinary team meeting happening on at least a monthly basis in each of our GP practices. That has been hugely successful. And one of the biggest successful things around it is not only by having sort of health, there's social care in the table, there's mental health workers that work in there, but we've also created social prescribing. So we've got our Integrated Plus, which is our locality link workers. So these are the workers we've actually commissioned from the voluntary sector who actually go in and do a full assessment. And there's been some huge successes. A lot of these people are actually socially isolated, and that is predominantly while their health is sort of worsening. So it isn't actually a health issue that is our issue. It's about joining them back up to the system, and that's been a great success. The other thing we're working on is having some kind of single point of access. The thing that people tell us time and time again is we don't know how to navigate the system. You've got to ring one number for social care, you've got to ring one number for health, you've got to ring a number for something else, and we're frustrated. We can't seem to get through to the right person. So another big thing of our model is having a single access point for people to ring to navigate, to get into the system when they have got issues and problems. Okay, so MCP, this is what it's about. It's about a system-wide approach. It's about secondary care coming together with community care, coming together with our primary care systems to have a system-wide approach, to have one contract. If you think about, if I take the example of diabetes, a diabetologist wants to achieve exactly what a GP practice does. But at the moment, you've got two systems who are paid on completely separate things. So you've got the GP practices that have predominantly been working on an outcomes-based contract, what was QOF. We've now moved to a local outcomes-based framework. But then you've got secondary care that they get paid every time they turn up at the diabetologist. So what we want to do is we want to create an integrated system that they're actually monitored and they actually achieve the whole outcomes across the whole system, work collectively together. Okay, so this is our outcomes-based framework. Like I say, it's got that key theme that I've already talked to you about the access, the continuum, and the coordination. What I can say is 40 of our 46 practices have actually been piloting what David was on about is the new framework, our Dudley Quality Outcomes for Health. So what we've done, we've actually taken what was good in QOF, so we've taken a combination of our QOF, our local improvement schemes for diabetes, palliative care, care homes and for COPD, and we've integrated those into it. We've also integrated a couple of the national DESIs, which was the learning disabilities, and also what has gone now, but was the avoiding unplanned admissions DES, into one framework. Primary care was telling us, we're submitting data here, we're doing this there, everything's overlapping and nothing is coordinated. So we've moved away from that, we've listened to what they said, they've been working with us in designing this new framework as public health. We've gone for a section of primary prevention, like we did within QOF. We've also commissioned a generic section of secondary prevention so that everybody with a long-term condition we know is having blood pressure checked, they're having depression screens, they're having alcohol screens, so move far more towards the preventative agenda. And also created a single template, so we've tried to marry that standardisation in primary care in the way that they deliver this framework in the future.
It's interesting that in the MCP contracts, the proposal at this point in time is that 10% of the funding comes from achieving those outcomes. So it's very strongly incentive-based and population outcomes-based. We were asked to say, what about STPs, we were asked, weren't we? So there's a little slide here that I'm going to do around the wider Black Country agenda, and I think there's just three things really to say. We're, as a public health community in the Black Country, we're embedding public health in the STP, both through developing a prevention framework, but also through making sure that the public health perspective is sort of represented in the various work streams. And the other sort of two key bits are that in each of the four local health economies in the STP area, 50% of the money in the STP, or around 50%, is about local place-based models. So innovative place-based models. Ours in Dudley is the MCP. Our colleagues in Wolverhampton, Sandwell and Walsall will have approaches that they're modelling around the local place-based approach. And then the other sort of 50% is around exploring horizontal integration across the 4 health and social care communities that we have in the patch. So our MCP and the local place-based models are really important elements of the STP. What I'm going to do now is just say a little bit about the sort of public health element of the MCP. Sorry for all the acronyms. The first thing I want to say is I'm not a person who harks back to when public health was in the NHS. I left the NHS early because I couldn't bear it any longer, because of the sort of the bureaucracy, the top-down command and control approach. I believe passionately that public health lives in local government. So for us, this isn't about sort of, oh great, let's get all the public health services back into the NHS, because that will sort everything out. That's not what this is about. I'm going to sort of talk through the rest of the slides to sort of help explain why that's the case. But what we have decided to, what we've been doing, and particularly Karen Jackson, while I was off, did a heck of a lot of work looking at zero-based budgeting, budget challenge, and what we found was that quite a number of our public health services prevent, and the prevention element of them impacts first and foremost on the NHS. So the first place they see an impact, they will see an impact on social care, they will see an impact on the criminal justice system, etc. But for quite a lot of our services, the first place the impact is the NHS. And really it's those services that we've put into scope for the MCP. So these are the services that are in scope. So sexual health and treatment pathway, which includes things like long-acting reversible contraception. We've commissioned a new integrated adult substance misuse service. When that contract for that is up, that will move into the MCP. That includes our bloodborne virus services and our substance misuse detox services as well, which we commissioned jointly with the CCG. We've just recently commissioned a new integrated adult wellness service which supports behaviour change. That will move into the MCP. NHS health checks, school nursing, a school health visiting and family nurse partnership, and we're in the process of designing and commissioning an integrated young people's wellness service, which will include young people's sexual health, young people's substance misuse, but also some emotional health and wellbeing services as well. So they're the services that we've put in scope for the MCP. The other thing that's really important in this process has been the council's governance processes and decision-making processes vis-a-vis the NHS top-down command and control, NHS England sort of approaches. So we've been very, very clear as a council about what the criteria are for adding other council services to the MCP. So any new services that go into the MCP will have to answer these 5 questions. One about reducing cost, one about meeting statutory and regulatory requirements, one around impacting on the outcomes for the people of Dudley, one around VAT. There's issues with VAT and council services. We also, as well as putting public health services into the MCP, one of the reasons that it was really important to me to do that was it gives us a seat at the table in terms of as a core commissioner of this massive 15-year contract. And we've got some wider public health aspirations for this new service model. You know, that by being around the table we can influence. So they're not just about the public health services, but about all the services that are in the MCP. So, for example, prevention will be embedded in all of the pathways. We're really keen that the provider make sure that frontline staff deliver make every contact count, and also building on the experience from the multidisciplinary team, connect patients with the assets in their community, that they have healthy working practices, and that services are able to respond and be flexible to the different needs of local communities. And that the provider actually contributes to improving Dudley as a place, as a social value approach, contributes to our social, environmental and physical and economic environments. So I'm just going to finish with sort of key opportunities and key challenges. I think there's enormous opportunities for this approach. Many of our, as I've said already, many of our public health services deliver return on investment impacting on the NHS first. And at a time when, yes, we've got another year for the ring fence, but at a time when our resources are under incredible challenge, then the fact that we're actually part of a system where the place where the money that's impacted on the saving is also responsible for the prevention services as well, I think that's really helpful. This is about an integrated model based, as someone who's been in public health for a long time and is quite old-fashioned, this is community-oriented primary care. That's what this is, with a new name. So this is a population approach, and so there's massive opportunities from a public health perspective. And it gives us opportunities to really test out new approaches to wicked issues, such as particularly frailty, which is a real challenge for us all. And what this does is it enables us to retain the public health services with synergies to other council services within local government. It enables us to really focus our energy on the determinants of health that we're really well placed to address within local government. In terms of the challenges, and I will finish, I know I'm a minute over, in terms of the challenges, I've already alluded to the NHS England command and control approach. This has created an industry, and I've been at a meeting, the reason I wasn't here this morning is because I've been at an MCP meeting this morning. What started as a really creative, innovative, locally based approach to meeting our population's needs better has, I'm sure Joe will agree, turned into something that makes world-class commissioning look like just a little bit of a thing in the corner. Another key challenge from a public health perspective is that we haven't actually got any evidence of impact on the key challenges that David put up right at the beginning, in the coloured explosions. Yes, we've seen some impact perhaps on reduced length of stay, yes, in demand for general practice, but on those big challenges, the model hasn't delivered that impact yet. It's too soon to show that. I think ensuring a strong local authority voice in the process is a massive challenge and taking up a heck of a lot of our time, my team's time. The people from my team in the room are all heavily involved in this. And also the timescales that enable appropriate local authority governance and health and wellbeing board oversight. There's a real challenge there with the time you need to do that and some of the timescales that NHS England are imposing. I've mentioned the uncertainty over long-term local authority funding. The other key challenge for us is the registered versus resident population, and any major changes to the practices that end up in the MCP as it starts to threaten the place-based approaches from our point of view as a council. So that's why that last one around maintaining a place-based approach is there. So in conclusion, exciting times in Dudley. I think this is the consequence of a lot of collaborative working. Public health has been involved right throughout the process, co-designing and we haven't been sort of brought in to do bits. We've been part of the whole design of this process. Real impact on embedding community asset approaches. And real opportunities, as David mentioned, around intelligence, information, analysis, data sharing. And ultimately, this is incredibly strongly clinically led as a model of care, and I think the benefits of that are fantastic. It's a great sort of culture to work within.